funny. So anyway, y'all can work on it. How's that? You're not going to get their attention either. That's the problem. So hey, we're on the other side here. How do you feel about that? I saw some really good scores on the exam. I was tickled pink. You all should be very proud of yourselves. I'm very proud of you, and I'm more proud than I am a yeller over an open mic. How's that? I'm really impressed, actually. Yep, the real work will now begin. So looks like most of you conquered the math too, huh? Because I wasn't sure how many of you were going to pull that off, really. Um, but it looks like pretty much people got it right instead of this sort of thing, which I thought was pretty funny and I would share. I think there were actual real answers on the math. You know? This is good, isn't it? Yeah, it's a good one. Exactly. So anyway, I think I saw some really really good work there. Again, you should be proud of yourselves for it. It was a lot of hard work. Yeah, there's a lot more ahead, but good on you. Yip yip hooray! Good stuff. And Bob does need to stop eating all that candy. He will have diabetes. Oh boy. So I don't know why this is fast forwarding on its own. Where are we here? Is that the first slide? No, there's the first slide. All right, I was confused for a minute. So we're going to be doing 2 evenings. Here we are in cardiology. So exciting. Um, we're going to be doing 2 evenings of just going over these cardiac drugs, doing a little bit of a deeper dive, touching on some of them we didn't talk about in the prelude lecture in pharmacology on the cardiac drugs. So can I help you guys with anything before we get started? Any questions or comments from me? All right. We're going to start over on L Blackboard. And I've put some stuff over there, and we'll go work on that a bit and see where that gets us. And we'll come back and we'll look at a bunch of slides. Do the same thing next time. All right. So I've grouped medications here to try and help you own them based on where we use them, right? So we're going to start off looking at cardiac arrest drugs, and specifically, as we've mentioned, and as you will certainly learn much more about, there's 4 essential types of cardiac arrest. I mean, that's in terms of rhythm stuff. We got our shockable rhythms, VFib and pulseless ventricular tachycardia, and then we have rhythms or conditions where defibrillation is not indicated, asystole, or something you'll learn much more about called pulseless electrical activity. It's not a rhythm; it's a condition where you have a organized rhythm on the monitor, other than VTAC, because VTAC would be a shockable if it's an arrest, right? But any other organized rhythm, but the patient is pulseless. So it's pulseless electrical activity. So it is treated similarly to asystole, does not involve defibrillation. But let's look at the first drug that, until they tell us not to, we're going to give in any cardiac arrest, and that's our epinephrine, 1 to 10,000 solution. I guess we're supposed to call it something different now. We're supposed to call it 0.1 milligram per milliliter. It's just another way. I'll probably use them both as we have our discussions along the way. But until they tell us not to, that is the first drug that we give in any type of cardiac arrest, whether it's shockable or not. And in adults, which is all we're dealing with here, is adult dosing. 1 milligram of that would be given, and it can be repeated. So everybody know that's what the Q stands for. Every Q stands for every. So 1 milligram every 3 to 5 minutes throughout the arrest. So that's your epinephrine. Anybody carrying vasopressin pre-hospitally right now? Any takers on that one? Well, for a number of years, we were using it as an alternative to replace the first or the second dose of epi. Then American Heart said, meh, not really. Just kick it to the curb. We still used it in a critical care setting more as an infusion. Um, so because it's not standard ACLS, I'll refrain from burning up airtime right now on it. But you never know, it might come back around. I will say that some critical care docs thought that vasopressin did a better job of salvaging the patient's brain than did epinephrine. But we'll stick to the epi, stick to the script. And so that doesn't matter if it's shockable, VFib, or pulseless VTAC, If it's non-shockable, asystole PEA. Epi is your first drug. Now, let's move on down and talk about the drugs in addition to epinephrine that we can consider in a patient who is in a shockable cardiac arrest rhythm. And we're going to pick one of these and we're going to stick to it. We don't like to mix these drugs, especially the amiodarone and lidocaine. We'll see doctors doing that sometimes, but it can create what's called a pro-arrhythmic effect, meaning you can generate a rhythm that it becomes nigh on to impossible to get the patient out of. So it can create a refractory state of arrhythmia. So we don't like to mix up those drugs. It's not a good look. Somebody does have an open mic. If you guys see who it is, we'll try and fix them. I can't get to it right now because I'm sharing my screen and I can't see who it is. Okay. Oh, I can see it's actually. I can see it's Sophia. I'm going to mute you if I can. I don't know why. Oh, she's muted now. Okay. All right. All right. Anyway, um, so we pick one and stick to it. We don't want to give amiodarone and then switch off to lidocaine. All right. That's okay, Sophia. So in adults, and again, we're only dealing with adult dosing right now. Your first dose is 300 milligrams IV push, right? And if you do repeat it, you would not give the same dose for your second round. It would be 150 milligrams. And if we just quickly, and again, we'll be getting into the details of this for sure later on, but just to get a sense, you determine someone is in cardiac arrest. Of course, immediately start CPR, get the pads on the patient as soon as possible. Um, and you want to pre-charge your defibrillator. All right. And as soon as you've got everything ready, we can briefly hold CPR, see if the rhythm's shockable. If it's shockable, and let's say it is, because we're talking about shockable rhythms right now, we would defibrillate and then immediately go back to CPR. Now we're in a 2-minute cycle, right? We don't do 2 minutes before we shock. We want to shock as soon as possible, okay? Because we don't want to let a shockable rhythm go on without treatment. So once we get in this 2 minutes of CPR, this one will get our vascular access, okay? Um, and then at the end of 2 minutes, if it's shockable, we're going to defibrillate. Then we're going to get back into another 2-minute cycle of CPR. You've got your IV now. Let's go ahead and think about a drug. And again, it would be our very first drug. What's our very first drug? Epi, right? So at this point, you go ahead and you give your 1 milligram of epi, right? And advanced airway could be taken care of along this path as well. But again, you come up on 2 minutes. If it's still shocked, we're going to shock it and then get into another 2-minute cycle of CPR. And during this 2-minute cycle, if it's still a shockable rhythm, this is where we'd be thinking about one of these medications, right? Pick one and stick to it. Let's say we picked amiodarone, so we gave 300 milligrams of amiodarone, okay? Um, and at the end of 2 minutes, if you're still shockable rhythm, defibrillate, get back on the chest or in another 2-minute cycle of CPR. Now you're going to go back to your epi, okay? And then at the end of 2 minutes, if it's shockable, shock it. You're in another 2-minute cycle of CPR. Now we would go back to our antiarrhythmic, okay? So we give our medications during the CPR cycle and we alternate. We give epi, next drug, next time a drug during the next cycle, amiodarone, then during the next cycle back to epi, and now back to amiodarone. And this is where our second and only other dose of 150 milligrams would be given, right? And then it would just be epi every 3 to 5 minutes after that. So you're going to run out of road after your second amiodarone. Now, what if it was lidocaine was your chosen poison instead of the amiodarone? Well, instead of the amio, you'd be plugging in YL lidocaine, right? And it's up to you. Do you want to give 1 milligram per kilogram or 1.5 milligrams per kilogram? Let's go big or go home in this case. So 1.5 milligrams per kilogram of lido. Okay. Again, we give our drugs during the compressions and we alternate between epi and our antiarrhythmic. Then we go back the next 2 minutes to our epi. And here, second dose of lidocaine is half of the first. Since I gave 1.5 megs per kg, my second lido dose would be 0.75 megs per kg, right, of lido. And that gives me um, the capacity to give another dose. What is 1.5 and 0.75 together? What's that add up to? Yeah. So could that means you could give one more 0.75 meg per kg dose of Lido because you max out at 3 megs per kg. Is that correct, folks? So you run out of road after your second amiodarone. If you're using lidocaine, again, you always alternate with the epi. There would be another 0.75 megs per kg you could give, and that's when you hit your max dose of 3 milligrams per kilogram. So anybody have a question on what I just did? Again, we'll certainly be going over this in a lot of detail along our path together. But this gives you a window into the approach, doesn't it? Now, what if the patient was in a shock with cardiac arrest rhythm, but the actual rhythm was something you'll learn to recognize called torsades de points? Well, then we would not give amiodarone or lidocaine. We would instead give magnesium sulfate. It is specific for this shock with cardiac arrest rhythm. And the full dose range 1 to 4 grams. Most people are going to start with 2 grams. And again, it always must be diluted. You can never just drop the mag and give it, right? So that's our for shockable rhythms. Now, in the asystole PEA, again, the only medication that's generic for non-shockable is our epinephrine. Okay, so that's looking at MADs, organizing them by uh, cardiac arrest. Let's move over and review medications that we use for tachydysrhythmias or tachyarrhythmias. And again, these are rhythms that are fast, but they're also abnormal rhythms, not sinus tachycardia. It's not your normal rhythm just going fast, right? It's an abnormal rhythm. It's a dysrhythmia. So it's bad and it's fast. Those are tachydysrhythmias. And as we looked at in our preliminary discussion on these drugs, we want to uh, organize them based on whether it's in a patient who is in a rhythm that originates above the ventricles, something that is a supraventricular rhythm, right? Or whether it's a rhythm that originates down in the ventricles, right? Uh, there are several rhythms that can originate above the ventricles, and I want us to look at those first. So let's move on down, and let's talk about the SVTs, right? SVT stands for supraventricular tachycardia. There are other rhythms that are supraventricular other than SVTs. Atrial fibrillations that are rapid, atrial um, flutters that are rapid. So not all supraventricular rhythms that are fast are SVTs. And you'll be learning all of this in some great detail. But there are a group of rhythms called SVTs, or if you see the rhythm start or stop, we say paroxysmal SVTs. So we witnessed it start or witnessed it stop. If the patient is stable enough for medication, our first line medicine for supraventricular tachycardias is our adenosine, right? Adenosine. And this is a drug that is given incredibly rapidly. Um, and you got to push a 20 ml bolus of fluid behind it. It's such a short half life. We need to get it to the heart before it falls apart. And our first dose is 6 milligrams per ACLS. Some of you may start with a higher dosing in your own protocols. But what we'll be talking about in school, we have to have some formula to stick by, is the ACLS dosing. Again, first dose is 6 milligrams, and it's given very rapidly with 20 ml bolus to chase it. If the patient remains stable enough for medicine and your first dose of 6 milligrams doesn't work, then you repeat it and your second dose is at 12 milligrams. Again, it's given very rapidly, 20 ml bolus to chase it. Now, some of you may have in your protocols a third 12 milligram dose, right? But right now, ACLS, which used to talk about 12 milligrams, now just talks about a second dose at 12 milligrams. So when you get in your paramedic license and you're practicing your own protocols, you may have something that's slightly different than this. But first dose 6 milligrams, second dose 12 milligrams, and the only rhythm that we use adenosine for is one of our SVTs. Okay. Now we have other bad fast rhythms that originate above the ventricles that are, by definition, supraventricular. Um, I know, Sam. I know. We'll have another discussion on another day. It makes people feel horrible, doesn't it? It really, really does. It is a very short half life. It goes away quickly, but I know it's you're talking firsthand experience, and I 100% am on board with what you're saying. But that is our first medication, right? Now, what if the patient remains in an SVT, but and stable enough for medicine, but the adenosine did not work for them? Do we have second line medicines for SVTs? And we do. Diltiazem is a second line medicine for SVT in a patient who remains stable enough for medicine. Or alternatively, metoprolol is a second line medicine for SVT. Okay, it's not a first line; it's second line. So, but the dosing is the same no matter if it's SVT or because it's a first line drug for atrial fibrillation that's fast or atrial flutter that's fast. And what is our diltiazem dose? And it's 0.25 milligrams per kilogram, slow IV push over 2 minutes. And if the patient doesn't respond to that but remains stable enough for medicine, it can be repeated one time at 0.35 milligrams per kilogram and given slow IV push over 2 minutes. So it can be repeated once in 15 minutes. So that's our second line dose for SVT drug, excuse me, second line drug for SVT. It's our first line drug for these supraventricular tachydysrhythmias, rapid atrial fibrillation, rapid atrial flutter. Here we would not use adenosine. Adenosine is only for SVTs. Our first line med would either be diltiazem for rapid atrial fibrillation or rapid atrial flutter, or alternatively, metoprolol for rapid atrial fibrillation, rapid atrial flutter. Okay, so diltiazem and metoprolol are second line drugs for SVT. If adenosine didn't work, the patient remains stable enough for medicine. But diltiazem and metoprolol are first line medications for rapid atrial fibrillation and rapid atrial flutter. Uh, well, you were talking about things that go beyond the scope of our discussion. When I say rapid, that what do you mean by RVR? It's rapid ventricular response. So when I'm saying it in plain speak here, it's the same thing, right? So rapid atrial fibrillation, rapid atrial flutter. And again, we're going to explore all this in some great detail coming up real soon. But here's our diltiazem again. Make sure you know 0.25 milligram per kilogram. Slow IV push over 2 minutes. Can be repeated 15 minutes at 0.35 milligram per kilogram. Or as an alternative, because we never give a calcium channel blocker and a beta blocker, that would be a disaster. You could crash their blood pressure and heart rate horribly. So you pick one, you don't mix them. But instead of diltiazem, maybe metoprolol. You get rapid AFib, rapid A-flutter, second line medication for SVTs. And here's your dose: 5 milligrams, slow IV push. Again, really over 2 minutes is a good way to give it. And you can repeat it at 5 minutes with another 5 milligrams, and in another 5 minutes if you needed a third 5 milligram dose. So the doses remain the same: 5 milligrams. You give up to 3 of them. And most books will say at 5 minute intervals, right? You might want to wait a little longer. That's why I put 5 to 15 minutes. But you could give 3 doses of 5 milligrams at, let's say, 5 minute intervals just to keep it simple. So those are the standard medications for bad fast rhythms that occur above the ventricles that are supraventricular. But what about the bad fast rhythms that occur down in the ventricles? And here we have, guess what? The same drugs that we looked at in cardiac arrest, shockable cardiac arrest, but yet the way we deliver the dosing is different. If the patient has a pulse and is in ventricular tachycardia, right, with a pulse, and they're stable enough for medicine, then we will give them 150 milligrams over 10 minutes. This is still a bolus. It's a medication bolus. It's not an infusion. But many of us are going to mix this in a bag and run it in over 10 minutes, okay? Just to keep yourself hands free. If I gave you 150 milligrams is 3 milliliters of the drug, the way it's supplied. If I gave you a syringe with 3 milliliters, 150 milligrams of amiodarone in it, said, I want you to give this over 10 minutes, I will guarantee you, inside of 2 minutes, none of that drug's going to be left. People just can't give things that slowly. What's the downside? What's the problem? What is a big concern if you give this drug too fast in a patient with a pulse? You guys tell me. What's the problem? What is the problem if you give this quickly in someone who has a pulse? What is the issue you're going to create? Well, it might not be that bad, but you're going to drop their blood pressure like a rock, right? Hypotension, huge. And it's a massive problem with the amiodarone, right? Hypotension. Now, it is a bolus, so how can you give it hands free? Well, let's look at that quickly. If I take a 100 ml bag of saline and I put the 3 milliliters, which is 150 milligrams of amiodarone in the bag, right? And I plug in a 10 drop set, not a micro drip, but a 10 drop set, and I want to drop this bag in over 10 minutes. So 100 ml is actually 103, but we'll just keep it simple. 100 mLs over 10 minutes would be essentially giving 10 mLs every minute, right? If you want to give 100 mLs over 10 minutes, you're going to give 10 mLs every minute. If you're using a 10 drop set, how many drops a minute would that be? to give 10 mLs a minute. Yeah, 100 drops a minute with your 10 drop set. So it's still a bolus. We're not giving an infusion, right? But we're giving it in a hands-free manner. That's going to drop that bag in over 10 minutes. It's going to give a 150 milligram bolus over 10 minutes, right? So we never just quickly bolus this drug into a patient with a pulse. It will crash and burn their blood pressure, right? It's not a good approach. If you will have a pump, you want to put it on a pump. Um, yeah, um, you have to figure out the math on that, right? So this is the bolus. Now there is also an amiodarone infusion, and some systems may want you to use an infusion after the bolus, and it is 1 milligram a minute. So this is an amiodarone infusion. How are you going to mix that? How are you going to give that? Well, let's take again a 100 ml bag of saline, and my dose is a milligram a minute. So the easiest way to do this is to put 2 mLs of the amiodarone. Again, amiodarone has got 150 milligrams in 3 milliliters. So I only want 2 mLs because I only want 100 milligrams. Put 100 milligrams in the bag. Now I'm going to hook up my 60 drop set, or I could put it on infusion pump, right? But I want my 60 drop set here. And if I want to give if I want to give a milligram a minute, that would be 60 drops a minute, wouldn't it? So if you are using an amiodarone infusion, you don't have a pump, just plug in your 60 drop set. 60 drops a minute will give you 1 milligram a minute, right? Because concentration on hand in this bag is 1 milligram per milliliter, right? So 1 ml is 1 milligram, 60 drops a minute. If you're on an infusion pump, put your pump tubing on and set it up for what? Since you did your math on a 60 drop set it up for 60 mLs an hour, right? So if we would jump into a little adjacent math here. So those are same two antiarrhythmics we looked at in cardiac arrest, amiodarone or lidocaine, right? Round down the room, so move up here. Again, if they had VTAC with a pulse, now this is where a lidocaine infusion comes into play. You don't worry about that in the arrest, but if we are using lidocaine instead of amiodarone, again, your dose is still 1 to 1.5 milligrams per kilogram IV push, and it's a dealer's choice, whichever one you want to give. Um, so you administer it IV push. If you fix the problem, if you fix the VTAC, patient goes back into a good rhythm, then what you want to do is to go to the infusion because we want to keep the problem fixed. The lidocaine bolus fixes the problem. The lidocaine infusion keeps the problem fixed. In other words, it maintains an adequate blood level to hopefully ward off the evil demons and the return of the VTAC. So you bolus them, you fix the problem, then you hang the infusion. We've talked about how to mix it, 1 gram in a 250 bag or 2 grams in 500, which gives concentration on hand 4 milligrams per ml. We've looked at the lidocaine clock. And most people will start at 2 milligrams a minute. If they were elderly or had a bad liver, we might start our infusion at 1 milligram a minute. But with the clock, you don't have to do math. 2 milligrams a minute, it's 30 drops a minute with your micro drip set. And you would just leave it like that. But what if your patient went back into VTAC with a pulse, was stable enough for medicine, and you needed to rebolus them? Well, you're going to give them half what you gave them the first time, right? And once you have done that and fixed their problem, because the bolus fixes the problem, then you come back to your infusion and you're going to increase your infusion to 3 milligrams a minute, right? The infusion keeps the problem fixed. So if they went back into the VTAC, you'd have to rebolus them. Once you get them out of the bad rhythm, you would increase your infusion by 1. So if you had the infusion running at 2 milligrams a minute, then they went back into the VTAC, you rebolused them, and again, your second dose is half the first. And then you would once you fix the problem, then you would increase your infusion by 1. You never go more than 4 milligrams a minute on the infusion. So that's how lidocaine is given in a patient with a pulse. And the bolus is to fix the problem. The infusion is to keep the problem fixed. Okay. Now, if it worked worse odds, you'll be learning what that looks like. Then no amiodarone, no lidocaine. We want our magnesium sulfate. And we'd be giving between 1 and 4 grams. Most people might start at 2 grams. Again, this must be diluted. If you're giving it in a patient with a pulse, you're probably, again, going to want to mix in an 100 ml bag. Or if you got 50 ml bags, that'd be fine too. Put 2 grams in. and then run it in over 10, 15 minutes, something like that. All right, depending on what your protocols or the orders are for it. But same big three that we looked at for shockable cardiac arrest rhythms, but here we're looking at people that have a pulse, are stable enough for medication, and have a bad ventricular rhythm, right? How we doing? Any questions? Am I breeding questions? Is this starting to sound familiar to you now? You starting to get the sense of this stuff? Any feedback, guys? Anything before we forge ahead? Oh, God. Well, what if we get our patient who is in cardiac arrest back with pulses? We get ROSC. That's always a good thing. Then we uh, may well need to give them blood pressure support post arrest. And these are the big three: dopamine infusion, epinephrine infusion, and this is actually all dosing. I'll fix that. It's 2 to 10 mics a minute. I won't take this away because if you needed long term, you would use this. But the upfront dosing is, oh shoot, I just messed that up. Um, 2 to 10 micrograms a minute for epinephrine or norepinephrine. So here's how you mix these, and you should have that on your drug cards by now. 400 milligrams and 250 for dopamine, or 800 milligrams and 500. Use your concentration on hand of 1600 mics per ml. We never start lower than 5 mics per kilo per minute, so we'll start at 5 and titrate up to get our desired effect. Alternatively, an epinephrine infusion. How do you mix it? 1 milligram of your more concentrated 1 to 1000 drug in a 250 bag gives you a concentration on hand of 4 mics per ml, and your dose is not weight based initially, 2 to 10 mics per minute. Or alternatively, a norepinephrine infusion. So mixing 4 milligrams in a 250 bag of saline, concentration on hand 16 mics per milliliter. And here it is weight based dosing, 0.1 to 0.5 micrograms per kilogram per minute. Obviously, you start at 0.1 mics per kilo per minute and titrate up till you get your desired effect. More and more, we're moving away from dopamine because it, in and of itself, can cause some dysrhythmia, some abnormal rhythms, more so than the epi infusion or norepi infusion. But again, some of you may not have all of the options. You're going to use whatever your protocols indicate. Okay. But if we need pressor support, these are the big three for post arrest. And probably most are going to be gravitating to norepinephrine or epinephrine, right? First, we try some fluids, but we're not going to just sit and give fluids and twiddle our thumbs in a post arrest state. This is a very unstable patient who could easily arrest again. So, and you've probably been giving fluids during the code already. So you may be giving fluids, but you should be pretty quickly setting one of these infusions up if they need it because their blood pressure is low. So how are we feeling? That's what we're going to cover tonight. We'll be talking about bradycardia next time, but I did put it up here on this slide to show you that dopamine and epinephrine, same mix, same concentration on hand, same dosing, is also in the bradycardia treatment for patients with symptomatic bradycardia, in addition to the old atropine. So that's a quick rundown. Let me just review quickly what we did here. We looked at drugs for cardiac arrest, epi, any type of cardiac arrest. And then we looked at the drugs that, in addition, are antiarrhythmics for the shockable rhythms, either amiodarone or lidocaine, and then torsades, magnesium sulfate. Then we looked at rhythms that are bad, fast, and originate above the ventricles. The first is a group of rhythms called SVTs. Then we use adenosine, 6 milligrams, rapid IV, repeat at 12 milligrams if needed. Second tier drugs for SVTs, diltiazem and metoprolol. Diltiazem and metoprolol are also first hand drugs or first level drugs for rapid AFib or rapid AFib. We looked at bad fast rhythms originating the ventricles with a pulse. Again, the same big three: amiodarone, lidocaine, or MAG if it's torsades. But we looked at for amiodarone, we looked at how we give it over 10 minutes, which is absolutely critical. We did a little math to figure that out. We also looked at the amiodarone infusion. Some systems may want you to follow up with the infusion after the bolus. Then we looked at our lidocaine. We looked at the bolus dose, and again, the bolus fixes the problem. Once the problem is fixed, the infusion keeps the problem fixed, and we looked at the infusion as well. And then we also looked at magnesium sulfate for torsades. And then for post-arrest blood pressure support, we looked at the big three infusions: dopamine, epi infusion, and norepi infusion. All right, so let's go look at some slides now. We start off with our sympathomimetics. So these are things that act like the sympathetic nervous system: our catecholamines, our epi, our dopamine, our norepinephrine, right? And here's the two concentrations of epinephrine. The 1 to 10,000, which can be given in an IV. The 1 to 1,000, that is never directly given IV, but could be used to mix an epi infusion, right? Whoops, I clicked 2 slides. I did. All right. We could describe this as a sympathetic agonist. It acts like sympathetic nervous system. Epinephrine is truly fear in a bottle, right? It really is. And there is, we never give epinephrine for any condition that is not either life threatening or an arrest situation where they're already, in a dire straits. So epinephrine is not never given for mild or moderate conditions, right? Things are really bad. You're thinking about the epinephrine, right? So it naturally occurs in the body. Our body manufactures it. It is endogenous, and it is a catecholamine. Catecholamine describes epi, norepi, dopamine, and that really has to do with the chemical formula for the molecular structure. They're amines. They're catecholamines, but you'll often hear them referred to as catecholamines, right? Epi, norepi, dopamine, and they're endogenous. The body makes all three of them. Um, Epi certainly has potent alpha and beta effects, and it has more powerful beta effects than alpha. I say it's a big beta, little alpha. By the way, why are we giving epi in cardiac arrest? Are we giving it for beta or alpha effects? I've got one person with the right answer. Two people. Three. No, not we aren't giving it for beta effects in cardiac arrest. In fact, those are maybe some nasty effects. That's beating the crap out of a heart that's already struggling. The beta effects are actually not very desirable in a cardiac arrest. We're looking for alpha effects. We're looking to get the blood back to the core of the body, back to the heart, right? So it's all about the alpha effects in cardiac arrest. Um, nope. Beta beats, right? Beta is inotropy, chronotropy, dromotropy. The beta 1 receptors are in the heart, but it's really the alpha receptors out in the periphery, the alpha 1 receptors, squeeze the blood back to the heart. That's the reason we're giving it in cardiac arrest. Okay. If we were hanging an epinephrine infusion for bradycardia, we'd be looking to increase chronotropy, right? And that's a beta 1 effect. If we were giving it to increase the force of myocardial contraction, that too is a beta 1 effect, right? Now, LP is big beta, little alpha, but it is alpha effects we're looking for in cardiac arrest, right? So it acts on both alpha and beta receptors, but more profound action on the beta 1 receptors or beta 2 receptors as well. Um, that again increase inotropy, chronotropy, dromotropy, right? But the alpha effects make the tank smaller, push blood back to the core, increase the blood pressure by smaller tank. Um, yeah. When you give epi IV, it works very, very quickly. Um, no, you don't want. That's not a goal of epinephrine at all in cardiac arrest. Nope. Um, nope. The beta effects actually can be harmful on the heart, which is why a lot of us are wondering how long we're going to continue to give it every 3 to 5 minutes. Right? The discussion has gone on forever. That's not based in a lot of science that we've done forever because of those beta effects. Not good in the arrest. Good in for other patients for other reasons. Not in arrest. If you're giving this IV, boy, it's going to kick in really quick. But if you look at duration, 5 to 10 minutes, half life 5 minutes, that's why the recommendation is in arrest, repeating it every 3 to 5 minutes. So again, shockable cardiac arrest or non-shockable cardiac arrest. And we're not going to talk about other emergency uses for it. Certainly we will. We get into medical emergencies later on. Let's stick to the cardiac stuff. Um, stick to the cardiac stuff. We need to protect this from light. It is light sensitive and it can degrade the efficacy of the medication. And it also can be deactivated by being exposed to alkaline or high pH solutions, like bicarb. Bicarbonate will deactivate basically all of the catecholamines, epi, norepi, and dopamine. So if you were in a situation where bicarb was going to be given in a patient who was receiving IV epi, you'd want to flush that line very well before you administered it, because otherwise you're just annihilating the effect of the epi. Okay, I think the same would be true for norepi or dopamine. They don't work; they're deactivated in alkaline solutions. Yeah, you might need to reboot or change your browser, or whatever. Go hard. It's on you. All right. Side effects. Again, it's fear in a bottle. So people that are in arrest don't generally complain, but people that might receive epinephrine who have a pulse, you don't see anything either. Is anybody else having that problem? It may be the browser you're using. Uh, if you're using a tablet, it might be what the problem is. Get on a computer, change your browser, see if you can square it up. Okay. All right. So again, epi is fear in a bottle. So in any patient who has a pulse who receives epinephrine, it can certainly cause them to become shaky, develop palpitations, anxiety. People get really tremulous, headache, dizzy, nausea, vomiting. And again, it does make the heart work harder, right? So it certainly can increase myocardial oxygen demand. Fear in a bottle. And because antidepressants monkey around with the neurotransmitters like norepinephrine, um, it can intensify the effect of epinephrine. We talked about cardiac arrest dose, and that's enough of that. And we're not talking about medical uses other than cardiac arrest at this point for the bolus dose. But obviously, if a patient was receiving it that did have a pulse, we carefully monitor their blood pressure, their heart rate, so on and so forth. And as with all drugs, we got to make sure if they're receiving this drug IV that it does not infiltrate. Right. All right. We just looked at that. What about epinephrine infusion? Again, we're sticking to cardiac stuff here. So, in a patient who has hemodynamically significant bradycardia, in other words, they're bradycardic and they're sick because of their bradycardia, and the number one thing will be hypotension, right, or low blood pressure. Then we can mix the epi infusion, 2 to 10 mics a minute, not weight based. Again, post arrest as a pressor, 2 to 10 mics a minute. And if it ends up being over a long time, you may move to the weight based 0.1 to 0.5 mics per kilo per minute for the maintenance infusion. Please know how to mix that epi infusion 1 milligram, 1 to 1,000, and 250 bag. Norepinephrine, uh, trade name is Levophed. It certainly is another catecholamine, another sympathomimetic drug. It's big alpha, little beta, right? It's the sister drug to epi. Epi's big beta, little alpha. Norepi's big alpha, little beta. So it has powerful effects on alpha, but it does have some beta effects. It has some positive inotropic properties, for instance, and it may dilate the coronary arteries. That's a pretty damn good thing. If we're giving it for low blood pressure, it's not someone with a mildly low blood pressure. If we're pulling out norepinephrine, their pressure is really terrible, right? 70 palp or less. Um, if generally speaking, right? We've looked at mixing 4 milligrams 250. This gives 16 mics per ml, and our dosing is 0.1 to 0.5 mics per kilo per minute. Again, it's another catecholamine. If we're giving it to someone to get their blood pressure up, we need to make sure the tank is full first. Don't want to clamp down on an empty tank, right? Fill up the tank with fluid before you start squeezing down on it. So if they've got volume deficits, we don't want to give it. MAOIs, and hardly anybody's on those anymore, but they really can jack up your norepi levels. Uh, and so, and TCAs, tricyclic antidepressants as well. So avoid it if the patient's taking those. If they've got a blood clot blocking a peripheral artery or one of the arteries serving the gut, a mesenteric artery, blood clots in arteries, they should not be getting norepi. Uh, and what are some adverse reactions? Again, make sure the line is patent and free flowing because extravasation can cause necrosis. And any of these infusions, norepi, dopamine, or epi infusion, uh, really clamps down patients' peripheral circulation. They're very cool and can become even ischemic in their periphery. And people that end up on these things for any length of time in the ICU, they can start losing fingers and toes and stuff because it's caused so much ischemia to the peripheral tissues. So, uh, 0.1 to 0.5 mics per kilo per minute. Here we see how to mix it again. Uh, and that's all you need to know for now. You must be on an infusion pump. All right. Dopamine. Here's a pre-mixed bag, 400 milligrams in a 250 bag. Is there a threshold where it stops clamping? Oh, no, it just keeps going. It just keeps on going. So, pre-mixed dopa, this is a 250 bag, 400 milligrams. In 250 is 1600 mics per ml, standard mix, right? Again, it's a sympathetic agonist, just like our norepinephrine or our epinephrine. It's a catecholamine, just like our norepi or epi, right? Naturally occurring endogenous catecholamine. And it works on alpha, beta, and dopaminergic receptors. Uh, and it's kind of dose dependent, right? We start at 5 mics per kilo per minute. You're probably going to get more beta than alpha effects, but you will get alpha effects. And as you titrate higher, you're going to start seeing more alpha and maybe than beta, right? So it's dose dependent. So it's a relative of epi and norepi, um, and certainly can increase the squeeze. It's a positive inotrope. In fact, the trade name for dopamine is intropin, intropin. That kind of gives you a little window into the fact that it definitely affects inotropic effects, right? And you will read that, unlike, say, an epi infusion, it doesn't increase myocardial oxygen demand. I think that's personally a BS statement, but you could talk about it in terms of a relative situation, right? It's less uh, beating up of the heart, making the heart work harder than, say, an epi infusion might be, right? But to actually say it doesn't increase myocardial oxygen demand, I think it's a little flimsy. I don't care if you know this right now. Again, we are using it, say, post arrest. We'll also talk about it in cardiogenic shock. We'll learn more about the use of it there, as well as things like epi infusions or norepi infusions. But it's also a cardiogenic shock. It can increase the squeeze in a big, baggy, sick heart. And then it also is an option in the patient who has hemodynamically significant bradycardia. In other words, bradycardia, and they're sick because of their bradycardia. And remember, and we'll talk about it again when we look at bradycardia next time, all people die eventually. APDE, all people die eventually. Atropine, pacing, dopamine, epinephrine infusions for bradycardia. All right. There is a tumor that can grow in the adrenal gland known as a pheochromocytoma, which is a fun word to say. And it's pumping out epi, norepi like crazy. So these are patients that shouldn't receive it because they're already pumping out large amounts uh, of it on from the tumor. Of course, you're not going to know that necessarily in the cardiac arrest, right? And dopamine, as well as your other epi, norepi infusions, can worsen dysrhythmias both above and below the ventricles. But dopamine is becoming more acknowledged as being more likely to cause dysrhythmias than the norepinephrine. That's why we're backing away from it a bit. But it is catecholamine, so it can make you all nervous, headache, dysrhythmias, palpitations, chest pain, nausea, vomiting. Yeah. As with the other catechols, they are deactivated in an alkaline solution. Again, if someone's on MAOIs, which hardly anybody is anymore, dosing should be greatly reduced because MAOIs crank up norepinephrine levels in the body. And if someone is on phenytoin, which is dilantin, interestingly enough, by the way, phenytoin also is not only used as a drug to treat seizure, but it also is a class 1B antiarrhythmic, same category that lidocaine is in. It's a sodium channel blocker. And interestingly enough, it can precipitate hypotension, which is not what you want with the dopamine, if someone is also getting dilantin. So that's an unusual thing right there. Please know how to mix it. We start at 5 mics per kilo per minute, titrate up till we get our desired effect. And with any of these infusions, once you get your desired effect, the last thing in the world you want to do is shut the infusion off. You never call turkey somebody just shutting off the drug, right? Maybe you've overshot your mark now. The pressure's going too high, or whatever. You got to titrate it back down, right? Never just shut it off. There's your dopamine. We'll skip by vasopressin. And we'll look at some blockers now. Sympathetic blockers. So we were talking about beta blockers, right? And of course, our centerpiece is metoprolol, which is low pressor. And it is more selective than some of the other beta blockers. It has less beta 2 effects, more beta 1 effects. Does that mean there's no beta 2 effects? I have a hard time believing that. It's less likely to have beta 2 effects. But does it dependably never have beta 2 effects? I don't think so. So would it be a good drug for the asthmatic? What do you think? If you're blocking beta 2 receptors? No. But it's less likely to do so than some of the other beta blockers, right? So it's more selectively beta 1. Okay. And again, we talked about it, second tier drug for SVTs, first line drug for rapid AFib, rapid A flutter, So we know it has negative chronotropic properties. And where in the conduction system does that really count? Well, it works at the SA node, but it's an AV nodal blocker, right? It slows conduction through the AV node. If we slow conduction, that must also mean, in addition to being a negative chronotrope, that it is a negative dromotrope, right? Reduces the rate of conduction velocity, specifically at the AV node. It can lower blood pressure. People are on it orally as an antihypertensive. That's not why we're giving it in our world, but certainly people are on metoprolol. And it certainly can drop cardiac output. Someone who is on a beta blocker and then, let's say, um, has gets gets in a motor vehicle accident and has internal bleeding. Is it going to inhibit their ability to become tachycardic? And the answer is yes, right? Because it's shutting down the sympathetic stimulation. So people that get shocky from volume loss, hypovolemia, whether it's blood or fluid loss, and they're on beta blockers, they may not show that early cardinal symptom of tachycardia that we otherwise see in compensated shock. Again, do you need to memorize all of this right now? No. But what I do want you to understand is this has a pretty long half life. So if there is a bad result from giving it, it's not going to go away real fast, okay? If the patient's body doesn't agree with it, it's going to be hanging out for a while. So again, second tier for SVTs that don't respond to adenosine. Again, all this has to be a patient stable enough for medicine. And first line drug for rapid AFib, rapid aflutter, right? And generally, we're not using it to treat hypertension. So why would we not give metoprolol? Well, they're bradycardic. That'd be a good reason not to. They're hypotensive. That'd be a good reason not to. They're in congestive heart failure. Uh, let's not reduce uh, the squeeze because it is going to have some negative inotropic properties, right? If it's blocking beta one, not a good look, and knocking down heart rate when they may need to increase their heart rate to keep things going in congestive heart failure. You're going to have to mouth this stuff about the blocks until you learn more about them. This is just stuff you say on faith until we get into cardiology more. But some of these blocks can cause slow heart rates, or they're blocks at the AV node. And again, this blocks things at the AV node. It's just going to slow things down more. It's a bad look. And again, let's avoid it because even though we say it's a selective beta antagonist, it still has some beta 2 effects and it's not good in the asthmatic, right? Carefully monitor the patient's vitals, heart rate, blood pressure, etc., and discontinue if the patient starts getting into a heart failure, gets bradycardic, showing signs of shock or heart block, or starts wheezing. So, bradycardia, hypotension, that's overshooting our mark, or a patient who is just reacting very strongly to it. Uh, lethargy, again, congestive heart failure, shortness of breath, wheezing, weakness. A lot of these are predictable side effects of a beta blocker. We never mix beta blockers and calcium channel blockers. Diltiazem, or another older calcium channel blocker, is for verapamil. So we don't mix beta blockers with calcium channel blockers. And use cautiously if they're on other antihypertensives. Dosing we talked about, there it is again. In adults, it's 5 minutes, slow IV over a couple of minutes. If you need a second dose after 5 minutes, give another 5 milligrams, and then another 5 minutes if you need more, a third 5 milligrams. You might want to wait longer than 5 minutes depending on what's going on. You never exceed 15 milligrams. And again, please give this drug slowly. I'm going to make a mention of Asmolol. Anybody carry Asmolol? Any takers on Asmolol? You were, and then you stopped. Do you know why, Lindsay? Just curious. Is it other services are starting to load it on? Okay. It is a very short-acting beta blocker. So, um, right, but no, you're thinking of another drug. You're not thinking of Esmolol. You're thinking of etomidate, Lindsay. You're thinking of etomidate. Esmolol is a beta blocker. I'm not going to go through dosing on it or anything, but it is very short-acting. When you stop the drug, unlike metoprolol, which you saw can hang around for a few hours afterwards, um, this will quickly stop. Let's go back to our discussion of epinephrine and cardiac arrest. Which are the good effects? Which ones are the desirable effects? Alpha effects. And which ones do we not like? The beta effects. So there are some systems that are giving esmolol during cardiac arrest to damp out the beta effects of the epi. Esmolol during cardiac arrest to damp out the beta effects. There are some medical directors that are looking at using it in cardiac arrest in other capacities, but it's not ACLS, so I'm not teaching you that. But now I think you can appreciate, after our discussion and reminding tonight about why we give epi in cardiac arrest, that this could damp out those damn beta effects that we don't like, right? So very interesting. So, and you can see that it probably is a short-acting drug since its trade name is Brevibloc, right? I'm not going to go through the rest of this stuff on Brevibloc though, as but there are systems that like the esmolol. All right, move on now to our anti-dysrhythmic drugs. Um, all right, and the Vaughan Williams classification system. We've got our sodium channel blockers, they're class 1 drugs. There's 3 subtypes. Our lidocaine is class 1B. Sodium channel blocker, notice phenytoin, which is dilantin, is also there. Um, so is anybody carrying procainamide? Um, any takers on procainamide? It is also a sodium channel blocker. It's class 1A sodium channel blocker. It is an ACLS drug. I do know there are some EMS systems that carry procainamide. Not sure if anybody in class can vouch for that in their service. Obviously, if you do use procainamide in your service, you make a drug card on it and learn it. You do, Sam. Okay. Um, and then we got our class 2 antidysrhythmics. Those are our beta blockers, right? Our class 3 antidysrhythmics are our potassium channel blockers, and there's our amiodarone. Um, our class 4 antidysrhythmics are our calcium channel blockers, and that would be our diltiazem. Then we have class 5 or miscellaneous, our adenosine, DIG, things that don't fit in the other categories, right? So, treatment and prevention of bad, fast rhythms, right? Certainly is an antidysrhythmic. Uh, it also has anesthetic properties, right? We explored that a little bit in our IO lecture, but it's certainly used and has been for oh so many years to treat life-threatening ventricular dysrhythmias. It's interesting. I think it was year 2000. I think it was year 2000. Um, is when amiodarone came on the scene through American Heart, and they downgraded lidocaine based on some, quite frankly, shabby science. Um, and as it later turned out, this wasn't anything that was talked about in polite company. But Wyeth Pharmaceutical, which was the manufacturer of amiodarone, paid a lot of money in 2020 to support ACLS. After that, they did have to start declaring conflicts of interest. But there was studies done comparing amiodarone and lidocaine in shockable cardiac arrest uh, in terms of the efficacy. And the studies that were done showed amiodarone, I would say, won by an eyelash. Maybe had a slightly higher number of people that were admitted that got ROSC. But if you looked on the other end at, you know, hospital discharge, there's really no difference between the two drugs. So even though uh, there wasn't a lot of difference in outcomes, everybody has kind of gravitated to amiodarone over Lido. But Lido is certainly a valuable drug and a reasonable option, and certainly an alternative in patients where amiodarone would be inappropriate. So there is now a resurgence. They tried to kill it off back in 2000, right? All in the name of bringing amiodarone forward. Amiodarone was not a new drug; it had been around forever. And the old timer nurses and docs are like, "Oh my God, they want to bring amiodarone on," because they saw what it did for long time term oral therapies, all the problems with the lungs and the thyroid and the liver, and it's a big bad nasty drug. So people were wow, but yeah, that was the year when amiodarone reigned supreme in American Heart, and thanks to Wyeth Pharmaceuticals, cha-ching. So lidocaine took a back seat, but it's back. It is another reasonable alternative. So how does it work? Again, it's class 1B, so it's a sodium channel blocker. And if you block sodium channels, you're going to slow depolarization, right? And you're going to slow automaticity. You're going to make it harder for the heart to fibrillate, which of course VFib never has a pulse because the ventricles are quivering like a bowl full of jelly. So it raises the fibrillatory threshold. Now, one of the downsides of lidocaine, and I have seen this in my practice, is the patient goes from shockable to asystole. That's maybe raising the fibrillatory threshold a little too much if you give a drug and it makes them go flatline and takes them out of a shockable rhythm. I have seen that once in a while. Um, so a little bit on the lido here. Um, what's the most important thing here? Peak of facts, 5 to 7 minutes, duration 10 to 20. That's why in a patient with a pulse, once we fix the problem, you may well be hanging the lidocaine infusion. Again, the bolus fixes the problem. The lidocaine infusion keeps the problem fixed. So VFib, VTAC, pulseless VTAC, or in patients who have pulse with VTAC and are stable enough for med, we aren't going to use them in MIs really. And we've downgraded the use in PVCs. You don't even know what those are. I'm going to skip by this stuff. We don't give it in slow rhythms, so it's not surprising it would be contraindicated. Lidocaine is got anesthetic properties, right? We're giving it in the cardiac, in the VTAC, or pulse if it's cardiac arrest, could be VFib, as well as a VTAC. So we're not giving it for anesthetic properties, right? We're giving it for sodium channel blocker effects on the conduction system in the heart. But it certainly does have numbing effects. And in a patient with a pulse, they can definitely start getting a little loopy. This is much more common. Someone who maybe has got a little impairment in their liver function, an older patient. It doesn't have to be with really big doses. You can have a patient get a little loopy do. Uh, I gave some lidocaine to a guy one day. He was having big runs of ETAC, and it fixes VTAC. But he got this goofy look on his face. And he said, "When are we going to get to McDonald's?" Of course, I had to make sure I didn't just dismiss that as nummy brain, and make sure I wasn't missing something else that had gone wrong with the gentleman. But it was lido nummy brain. That can happen. Another thing that can happen is it can promote seizure in someone who is vulnerable to it. Um, the place where I have gone a few times in my career was in the dentist's office. They use lidocaine, and other canes like buspicaine, bravocaine, other ones. Um, Novocaine, right? By the way, if someone's allergic to one of the other canes, don't give them the lidocaine, right? Um, but I've definitely been to calls at the dentist's office where they were given lidocaine or Novocaine, and the patient began to seize, have a generalized motor seizure. This is a side effect of lidocaine. Important to know, right? So it can cause confusion, it can cause seizures. Um, if you block sodium channels too much, you could drop the heart rate, cause IV blocks, make their blood pressure low. Respiratory cardiac arrest, those are bad side effects. I think they're pretty rare with this drug, but they can happen. Right? And again, use caution if you're giving it with procainamide. That's another sodium channel blocker. Phenytoin, another sodium channel blocker. Quinidine, another sodium channel blocker. So if you're mixing with other sodium channel blockers or beta blockers. Dosing, we've gone over that. I don't think I need to repeat it again. Um, it's up to you or your medical director. Do you give 1 meg per kg IV bolus for your first dose, or do you give 1.5 megs per kg? I would say if I have a choice, and my patient is elderly, or I know they've got underlying liver disease, I would definitely go 1 meg per kg rather than 1.5. Right. Remember, your second dose is half of the first dose, and we never want to exceed 3 milligrams per kilogram. And in a patient with a pulse, once you fix the problem, hang the infusion. Right. Hang the infusion, and start generally speaking at 2 milligrams a minute on the infusion. So again, in the elderly, dose should be reduced. People with liver disease, uh, dose should be reduced. And we're not going to talk about giving it down the tube. But there's your infusion. Again, know how to mix it, know how to administer it. There's a pre-mixed. This happened to be a 500 ml bag. It's got 2 grams of Lido in it. Again, concentration on hand 4 milligrams per ml. There's your Lido. And it is break time. So how you doing? How you feeling about what we're doing tonight? Is this helping? Am I going too fast? How you feeling about this? I begged you to learn this stuff. Good. Go. Are you figured out what was going on? Why you couldn't see anything? All right. Well, let's go ahead and take our break now. So I'll get our clock up and some tunes for our break. See you back in 15 minutes.
A long time ago, came a man on a track, walking 30 miles with a sack on his back. And he put down his load where he thought it was the best, made a home in the wilderness. Built a cabin and a winter store, and he plowed up the ground by the cool lake shore. The other travelers came walking down the track, and they never went further, no, they never went back. Then came the churches, then came the schools, then came the lawyers, then came the roads, then came the trains and the trucks with their load, and the dirty old track was the telegraph road. Then came the mines, then came the ore, then there was a hard times, then there was a war. Telegraph sang a song about the world outside. Telegraph road got so deep and so wide, like a rolling river. And my radio says tonight it's gonna freeze. People driving home from the factories. 6 lanes of traffic, 3 lanes moving slow. but they shut it down. I got it right to go to work, but there's no work here to be found. Yes, let me see, we're gonna have to pay what's owed. We're gonna have to reap from some seed that's been sown. And the birds up on the wires and the telegraph pole, they can always fly away from this rain and this cold. You can hear them singing down the telegraph pole all the way down the telegraph road. But I'd sooner forget. But I remember those nights. Yeah, life was just a bet on a race between the lights. You had your head on my shoulder, you had your hand in my hair. Now you act a little cold, like you don't seem to care. Well, just believe in me, baby, and I'll take you away from out of this darkness and into the day. From these rivers of headlights, these rivers of rain, from the anger that lives on the streets with these names. As I run every red light on memory lane, I see desperation explode into flame. And I don't want to see it again. From all of these signs saying sorry, but we're closed all the way. Down the telegraph road.
That was a fast 15. Huh, we're back. Moving on. We're looking at some adenosine. Sam is not a fan of adenosine, and I understand why. Because it does make you feel like crap, right? It really does. But it has a short half life. Um, what was your sensation, Sam, when you experienced it? You got 6, 12, 12, not a good day. So did it not fix your SVT? People feel like they're dying, though. That is a problem with this drug. Makes people feel just awful. Actually ended up converting. Oh, but you had a phenochromatocytoma. Oh, wow. Did they felt like you were dying? So painful. So you had burning in your muscles. That was your sensation. Like everything seized up. Yeah, I've had people describe all kinds of sensations, including the feeling of impending doom. Right. So it is can be unpleasant for people. I absolutely hear you on that. So, but we'll talk about it because it is an ACLS drug, first line for SVTs, if they're stable enough for medicine. Its seat of action is the AV node, slows conduction through the AV node. It actually is a naturally occurring substance in the body, adenosine. Maybe you've heard of a little thing called ATP, adenosine triphosphate. And once that last phosphate group's gone, adenosine diphosphate, based on adenosine, right? So again, it's an AV nodal blocker, and it definitely slows things down at that AV node. It can mess with these. When we talk about SVTs, we're going to talk about reentry circuits, electrical reentry circuits. This electrical thing, I call it's also known as circus movement. I call it a hamster on a wheel, where this electrical thing gets set up in a circle and just goes round, around, 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 around. And every time it spins around again, it just speeds up the heart rate. So it can interrupt these reentry circuits. Half life 10 seconds, right? Sometimes referred to as a chemical cardioversion, and tends to be effective in most cases. It can cause a brief period of asystole, though. No wonder people feel like crap. Maybe up to 6 seconds. Talk about, I mean, when you watch this happen to a patient, you slam this drug in and slam in 20 mils of saline behind it, watching the monitor, and instead of being this very rapid rhythm, they just go flatline. That's really the day you wish you wore your brown pants. All right. I mean, people are holding their breath, waiting for the rhythm to come back, right? And it can last like 6 seconds in some people. It doesn't always happen, but it can. Right. So onset very quick. That's why it has to be given very rapidly with the bolus behind it to push it to the heart before it falls apart. It has a very short half life. So we use it for SVTs or PSVTs. We wouldn't want to use it for slow things, and we wouldn't want to use it for any slow rhythm or in someone who is allergic to some component. Right. So it can cause transient asystole. And there's mixed reviews about asthma. Some people say don't use it in asthmatics. Other sources don't say that. In some patients, they may develop some bronchospasm um, from the adenosine. Do all asthmatics develop bronchospasm from adenosine? No, but it can happen. It certainly can make people feel like crap. Um, and I've heard similar stories to Sam, feeling like they just locked up. Right? I've definitely heard that. Headache, breath, dizziness, nausea. Some of the side effects. Again, transient asystole. Not as many people are on these type of drugs for asthma anymore, the methylxanthines. Um, but if they are, it may take a larger dose. And then there are other drugs like Persantine and Tegretol that may require smaller dosing. Again, 6 milligrams given very rapidly with a flush, and then can be repeated at 12 milligrams. Some systems repeat it again a second time if necessary. That's a little bit on adenosine for tonight. Here's our calcium channel blocker, our diltiazem. And it is a calcium ion antagonist. It's going to block calcium channels. Again, remember, calcium enters in, prolongs the depolarization in the conduction system of the heart. If you slow that, it's going to slow the process of depolarization, especially works at the AV node, and that can correct bad fast rhythms like SVT or slow down rapid AFib or rapid aflutter. Uh, Remember, calcium is critically important for muscular contraction, and if you block calcium, it's going to slow or it's going to impact the smooth muscle inside the blood vessels, for instance, and that can make the tank bigger, right? Which is one of the reasons it can drop out the blood pressure because it can increase tank size. It is also a negative uh, inotrope. That's not one of its better qualities to reduce the squeeze, right, in the heart. So we have to get this very slowly. Push a little, flush a little, push a little, flush a little. Keep your eye on the patient. Keep your eye on the monitor. When you see you've gotten your desired effect, stop pushing the plunger. But you can see why it could cause hypotension. So it causes vascular dilation, slows conduction through the AV node, can slow down AFib and aflutter to more tolerable rates. And when it was first approved for FDA, it was approved for something called Prinzmetal's angina, which is a condition where the patient will suddenly develop spasm in their coronary arteries. So that can cut off the blood supply part of the heart muscle, right? The coronary arteries, or a piece of them, goes into spasm. It's not, it's not the plaque rupture clot formation that we think of with MI, but it's still spasmed coronary artery is going to cut off the blood supply beyond that point, right? We're talking about Prinzmetal's angina in cardiology. So this is why it was first approved by FDA because it could terminate Prinzmetal's angina, relax the coronary arteries. So again, we give very slowly, but notice that the duration and half-life are quite long. So we don't want to overshoot our mark. If you did and the patient had a bad result, is there a reversing agent, something that you could use? Anybody know the answer to that? That you would want to have on hand? Calcium, yeah, calcium. Good, Yakov. All right. Um, so rapid AFib, rapid aflutter, second line for SVTs. We're not going to worry about it for chest pain beyond our scope. But again, it can cause low blood pressure. So again, wouldn't want to give it if someone was hypotensive. Wouldn't want to give it if they're in cardiogenic shock. Wouldn't want to give it for wide tachycardias like VTAC. And this is important. It would not be used in rapid AFib if the patient had Wolff Parkinson White. I'll teach you all about that later. For now, you'll just have to take that on faith. But certainly can drop out the heart rate over zealously and also drop the blood pressure. So we get very, very slowly, have calcium standing by. And we used to carry it in a different form. We had to mix it on the spot, mix the diluent with the powder. But that form of it, syringe, I guess it was just too pricey for the pharmaceutical company. They stopped producing it that way. And now it comes in a vial. If it's not refrigerated, it only lasts a month. That's why some services don't carry it because it goes out of after 1 month of being at room temperature, it's expired, right? Should be considered to be expired. So again, it could slow things down too much, cause heart blocks, cause hypertension, asystole. That's a bad look. Nausea, vomiting, dizziness, headache. Never mix beta blockers and calcium channel blockers. So there's your dosing again. Make sure you know it. 0.25 megs per kg, slow IV every 2 minutes. Can be repeated in 15 minutes at 0.35 megs per kg. Then here is the nuclear weapon of antiarrhythmics, our amiodarone. Um, Trade name is cortisone, and then the new generation of it, where they've removed the maybe one of the causes that created so much hypotension, um, the particular preservative that was in the older formulation. The newer formulation is called Nexterone, and it doesn't come in a vial; it comes in a pre-mixed in an IV bag. But this is a super duper blocker. It is listed in the von Williams system as a potassium channel blocker, right? A class 3 antidysrhythmic. But it also blocks sodium channels. It also blocks calcium channels. It also blocks alpha and beta receptors. It just blocks stuff. It's a blocker, 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 blocker. It really blocks stuff. It's a big gun. It is a nuclear weapon, amiodarone. So yes, it does block potassium channels, but it also blocks sodium channels, calcium channels, alpha and beta receptors. It blocks stuff. But they had to find a place to put it in the von Williams classification system, and it is uniquely positioned to block potassium channels. And if you block potassium channels, you're going to slow repolarization, right? Slow repolarization. at least that early repol with potassium exiting. If you slow that repolarization, then the system can't reset itself as fast to go again, right? And that is why it can stop some of these bad fast rhythms. Orally, it takes a while for people to get their therapeutic level. Of course, that is not true when it's given IV. And again, half life could be up to 55 days. It's crazy long, isn't it? Remember, it takes 5 half lives to get a drug out of the body. It takes nearly a year to get this drug out of the body. We're mainly using it for ventricular dysrhythmias, VTAC, VFib, but you will find doctors who use it for rapid AFib, rapid AFib, or SVTs. We're not going to be going there in our studies for the largest part. I want you to think about it for bad fast rhythms in the ventricles. We have drugs that are maybe safer to use for bad fast rhythms occurring above the ventricles. What are some contraindications? It certainly would be delivered to the baby in breast milk. Anybody that's got slow rhythms, we don't want to give it. And then someone has an allergy to iodine, we want to avoid it because it is heavy on the iodine in its formula, right? Not good either if people have heart failure because it blocks so many things. It can worsen heart failure, right? So obviously we want to watch, make sure we didn't slow things down too much, um, prolong different parts of the cardiac electrical cycle, uh, drop their blood pressure. Again, those are not things that we're going to see in an arrest patient, but if we're giving it in a patient with a pulse, right? If you look at the full prescribing information for amiodarone, it interacts with a whole bunch of drugs. It is a long list in the full prescribing information of drugs that don't play well with amiodarone. But here's just a few of them. Warfarin, which is Coumadin, Dig, uh, and then you've got 3 sodium channel blockers there for keinamide, quinidine, phenytoin, right? Here's our dosing again in arrest. We just delivered as a bolus. First dose in adults, 300. Second dose will be 150, and then you're all done. No more. We alternate it with epi, and again, the drugs are given during the 2-minute cycles of CPR. In a patient with a pulse, we give it over 10 minutes. We even looked at how to do the math on that, didn't we? Then here's our magnesium. And we'll find other non-cardiac uses for magnesium. I mean, it's a critical electrolyte. Many of us are magnesium deficited, and it's hard to recognize that because the lion's share of mag is inside of your cells. So if you look at an electrolyte panel where they're measuring mag, they're measuring what's in the bloodstream, which you would expect to be a much smaller amount because it's inside the cells. And with the current diet and poor quality of food and poor quality of soils, and a lot of people are low on their mag. But we're here thinking about it not as a nutritional thing, but as an antiarrhythmic. And we'll find other uses for it later in the program for other things. But let's stick to the cardiac stuff now. Magnesium, as I just said, is mainly found inside of cells. Where is calcium mainly found? Inside or outside? Now, muscles have internal calcium stores, but generally speaking, where do we find calcium? Outside. So, mag mainly inside. You changed your mind. And calcium mainly outside. On the periodic table of the elements, they're in the same column, the second column. And way back when in pathophys, I told you the body takes advantage of the similarity of things in the same column on the periodic table and uses them in opposing ways. We know that's true with sodium and potassium, right? Potassium mainly inside, sodium mainly outside. You can move those things around to get electrical activity going. Well, the same thing is true pitting calcium and magnesium against each other. Uh, in fact, magnesium is a calcium channel blocker. Interesting. So they're literally opposite each other in terms of their physiology in the body. Magnesium is a physiologic calcium channel blocker. If someone had too much calcium on board, could you give mag then? If someone had too much magnesium, could you give calcium? Yeah, they're like opposite in terms of their activities. So we have to dilute this stuff. But when you give it IV, it's going to have a very quick effect, right? We are focusing on its cardiac uses. And again, it's this unique form of VTAC called torsades de points. And that's what we'll focus on. We used to use it um, if you tried everything else in a code for shockable arrest and you weren't getting anywhere. You could try some mag. They've kind of downgraded that, but I'll have more intelligent things to say about that when we get into our studies and actually understanding the rhythms and not just mouthing words that you guys haven't had yet. So let's just focus on torsades for now. But again, none of these drugs are without side effects. And in a patient with a pulse, this can actually knock down or knock out the respiratory drive. That's not good. You have some bad effects. So don't give it in shock, hypotension, slow rates. Uh, really tough on someone who is in kidney failure. They're going to get hypermagnesiemic. They can't get rid of it. And because it's a calcium channel blocker, if they had low calcium, we wouldn't want to give them the mag, right? Has to begin very slowly, must be diluted. Used cautiously in patients with renal insufficiency. Have calcium available as an antidote, and they're opposite each other. Right? So magnesium can relax things, can relax smooth muscles, can relax your skeletal muscles, and relax muscles. Calcium can cause muscles to contract. Magnesium does the opposite, relax things, right? And in a patient with a pulse who receives this, it feels like you just injected napalm in their veins. They will be on fire. This is another reason it must be adequately diluted, right? Because that can reduce the effect a bit. But the other reason is it just burn the hell out of their veins if you didn't dilute it. But you give someone mag that's got a pulse, they will get really hot and flushed and sweat and feel like they're on fire. That is a fact. That's a fact. But look, it can knock out the respiratory drive, even put somebody in respiratory arrest, knock their blood pressure down, right? I think the reason people get hypothermic is because they get really hot and sweaty, and that gets them chilled, and that can lead to hypothermia, right? So there are no benign medications. They can all, have some evil side to their personality. And even though MAG is so useful, when it's needed, it can really work some magic. You have to be respectful for the downsides. Not good to mix with DIG. Digitalis, by the way, works by increasing the amount of calcium that goes into cells, which is why it can increase the squeeze, has positive inotropic properties. So basically, you're just countering the effect. So here's our torsades. Again, 1 to 4 grams. I put on the other slides, and it's because ACLS talks about 1 to 2 grams for doses, whereas most EMS systems use 2 to 4 grams for dosing. So that's why I put 1 to 4 grams. I figured I'd cover everybody's dosing, right? We'll often start at 2. And again, it must be diluted. So that's MAG. And that's the first part. We're going to do this again and hit on a bunch of other meds, and again, focus on the cardiac uses for them next time. So one more night talking about cardiac medications, and then, boys and girls, we are really and truly going to get into cardiology. It's going to be so exciting. So hopefully this little discussion tonight is helping you wrap your head around these drugs and become more and more familiar, learn some of their personalities, really lock down why we're grabbing for these certain medications for certain conditions, and own it big, because we got great cardiology ahead. So what say you before we end up for tonight? Anything? Don't all type at once. Well, then I'll see you back next time. No questions, no clarification needed, no comments.